Thanks very much. That's not actually a funny fact, and probably because I'm an academic, I don't have the capacity for humor all the time. But anyway, first I just want to tell you about the fact that I'm actually very new to GIS, and even though I have my PhD in global public health, GIS is not a huge component of our training, but it's becoming more interesting when you look at multidisciplinary methods to do analysis. And what we've done here, at least in the preliminary, is looked at how we can apply GIS to mapping out the distribution of counterfeit medicines. So if you don't know anything about counterfeit medicines or fake medicines or falsified medicines, there's a lot of different words for it, but it's basically medicine that's not the actual medicine that you're supposed to get. And it's a global problem, been detected all throughout high-income countries, low to middle-income countries, and resource-poor countries, and all through the global drug supply chain as well. So hospitals, clinics, night markets, unregulated sectors, all types of places. It's a big industry. It's been estimated at approximately $75 billion, but the statistics on it are really weak because it's a criminal transnational trade, and criminals aren't generally all that transparent about their business. So to be honest, this is an area where there's not good data, and we're trying to generate better data and better types of methodologies to assess the problem. So even though in the US here we have a very closed and regulated drug supply chain, we're not immune to this problem. So in 2012, the FDA sent out notices to 19 clinics initially that they had discovered counterfeit Avastin. Avastin is an anti-cancer drug that's used for a variety of cancers, and the product that was being actually administered in US clinics was cornstarch and some acetone, which is actually used as a paint thinner. So obviously you're not getting treatment if you're getting treated with cornstarch. And it was an injectable as well, so you're getting injected with this. What happened after investigations unfolded was this was actually a big global trade in this counterfeit product, all the way from Turkey, Switzerland, Denmark, the UK, and finally to the US. That's how the drug actually got here. This is part of a big area called the gray market, where a lot of pharmaceutical products can enter into this kind of unregulated space and enter into the controlled drug supply chain. The FDA ended up sending out about 1,000 notices at the end over a span of 2 years. So what we wanted to do is we wanted to use those notices and look at where they had been distributed, and then look at geographic correlates to see if they were associated with some type of risk behavior. So we geocoded for all the zip codes in the US, approximately 30,000, and then the zip codes where counterfeit Avastin notices were sent, and then we did some multivariate analysis to determine what demographic variables were associated with getting a notice. So, you know, we're still doing preliminary analysis, but basically, if you're over 65, you're more likely to get a counterfeit Avastin notice. And when you get a counterfeit Avastin notice, that probably means that that medical clinic purchased counterfeit Avastin, and actually administered it to somebody. Also, we found that people of Caucasian ethnicity were at higher risk for getting a notice. And this is kind of our very preliminary data which we're pulling, and then we wanted to map those demographic correlates to, of course, a base map. And the blue points show the first wave of notices that went out by the FDA, about 170. And the second wave is the green dots, and then we overlaid that with age. So we're trying to, or the number of people over age 65. So we're trying to determine what risk factors are associated with you getting a notification. And this is very preliminary, so we're not really sure about where this is going to lead us, but this is a new way that we can act to do better surveillance for counterfeit medicines. So the implications for this are that 3 years after counterfeit Avastin had been detected in the US, there were some Wall Street Journal articles that came out, and there were some news reports, but nothing's happened so far. There have been some legal prosecutions, so the second part of this analysis, this is just one aim of a larger research project, is to put the legal prosecutions and map those out, what type of clinics they have actually prosecuted against. And the Department of Justice has actually prosecuted only 17 individuals, and most of them were distributors and not physicians. And interestingly, no patient has ever come forward and asked for, sued anyone for this issue, even though they're the most impacted. So what we hope to do is to develop, through this kind of case study, a model for how you could do better drug surveillance. So if you have an adverse event, or the FDA has an adverse event with their drugs, they report it on their website. And we had to pull all the data from these letters that FDA sent, and it's not really all that consumer friendly. So what we'd like to do in the future is have the FDA have some sort of base map, have some sort of visualization that shows patients where adverse events associated with the drug recall, et cetera, show up so that patients can be aware of it and they can look to see if they have an adverse event associated with the drug. So that's the hope we have. Thank you. And I just want to thank the American Cancer Society for funding this. Thank you.